Henry K. Beecher, an anesthesiologist in World War II field hospitals, reported that severely wounded soldiers often needed less morphine than peacetime surgical patients with comparable tissue damage. In his post-war clinical writing, he tied the difference to meaning, relief, and care surroundings, not to the wounds alone. On the battlefield, a grave injury could signal escape from combat and a path toward survival. In civilian wards, the same scale of tissue damage often meant sudden catastrophe and threat. Beecher recorded that soldiers in the first setting frequently required less analgesic or refused it, compared with the peacetime cases he later measured against them. The injuries were real in both groups. The clinical meaning and the surroundings were not. The nervous system does not read tissue chemistry in isolation. It reads damage together with expectation, safety, and what the wound implies about the immediate future. When those signals favor relief, reported pain and morphine need drop even before an active dose is given. Beecher's observations entered the broader placebo literature. Later attempts to fix a single headline percentage on placebo response have been criticized on methodological grounds, so the durable core stays qualitative, expectation and setting changed pain reports and drug requirement. If the same injury hurts differently under different clinical meaning, pain is not only a readout of tissue chemistry. The same shift appears when nothing looks like a battlefield, only the color of a capsule. Pharmacy and experimental psychology reviews of multiple small controlled studies find that pill color systematically shapes what people expect and report from a medicine. Warmer colors, reds, oranges, yellows, associate with stimulation or stronger action. Blue tones associate with sedation or calm. Exact effect sizes vary from experiment to experiment, but the directional pattern is robust enough to surface in dosing form research and in controlled tests run beside pharmaceutical marketing questions. A 1996 systematic review in the British Medical Journal by De Crane and colleagues gathered that literature and documented the same color-to-effect mapping across studies. The mechanism is learned association and prediction. Through prior contact with packaging, labels, and cultural coding of medicines, the nervous system treats appearance as a cue about what the treatment will do. That cue feeds into how symptoms are monitored and described. A blue capsule is read as a calming signal before any molecule has bound a receptor. A red one is read as activating. Expectation is not a later gloss on pharmacology. It is part of the input the brain uses to construct the felt effect. So clinical context does not need trauma or life or death stakes to matter. Pigment on gelatin is enough. Framing is not decoration. It is part of the signal the body answers. In 2002, J. Bruce Moseley and colleagues reported a randomized trial in the New England Journal of Medicine on arthroscopic treatment for osteoarthritis of the knee. Patients assigned to sham surgery, skin incisions, and a simulated procedure without the debridement or lavage thought to be therapeutic, improved in pain and function about as much as patients who received the real operations, and those gains held across follow-up for many of them. The trial separated the operative ritual from the mechanical steps surgeons believed were doing the work. Everyone received anesthesia, the same preoperative framing, the same postoperative care language, and the visible marks of having been operated on. What differed was whether the arthroscope actually scraped and washed the joint. When the theater of care was held constant, omitting those mechanical steps did not erase the symptom relief. Expectation, the anesthetic episode, the incision, and the surrounding clinical performance were enough to drive durable change in what patients felt and could do. That result does not claim every operation is empty. It shows that a high-stakes medical performance can match real surgery on reported outcomes even when the tissue work labeled active is left out. The nervous system treats the full context, consent, prep, incision, recovery script, as a signal that can dial pain and function. So the ingredient list that names only debridement and lavage is incomplete. When the theater of care equals the operation on what patients feel, context is not packaging around the treatment. It is part of the treatment the body answers. Ted Kapchuk and collaborators showed that placebos can relieve symptoms when patients are told, outright, that the capsules hold no active drug. In an irritable bowel syndrome trial published in PLOS I in 2010, people assigned open-label placebos improved more than controls who received the same clinical interaction without the pills. The design kept honesty and care constant. Participants heard that the capsules were inert, that placebos can still act through conditioning and expectation, and that taking them on a schedule mattered. They met providers regularly. The comparison arm got equivalent conversation and contact but no capsule regimen. What differed was the empty dose framed as a treatment that mind-body pathways might still answer. The mechanism is prediction plus ritual, not a hidden pharmacological story. A credible medical frame, clear briefing, a physical object, a dosing schedule, repeated contact, still recruits the nervous system's learned responses to care. The active drug slot can be empty and known to be empty. Engagement and context remain signals that can shift reported pain, discomfort, and function. Related open-label work later found the same pattern in other symptom complexes studied with that design. The older assumption that placebo benefit requires deception does not hold. Honest labeling does not cancel the treatment context the body answers. Belief that a capsule hides a drug is not required for the body to answer the treatment context. In 1978, Levine, Gordon, and Fields reported that the opioid receptor blocker naloxone can reduce placebo analgesia. Later imaging and pharmacology replications in pain science reinforced the same point. Expectation engages endogenous opioid pathways. Their classic demonstration used postoperative dental pain and a controlled comparison of placebo responders with and without the antagonist. When people received an inert treatment in a credible analgesic setting and reported relief, naloxone blunted that relief. The drug does not supply pain itself. It occupies the receptors that the body's own opioid peptides would otherwise bind. If blocking those receptors shrinks the placebo component of pain reduction, the relief that followed the empty treatment was not only report bias or polite answering. Part of the work was neurochemical. The chain is prediction recruiting pharmacology. A clinical frame, the ritual, the briefing, the belief that relief is coming, activates descending pain control circuits. Those circuits release endogenous opioids. The opioids act at receptors in regions that gate nociceptive signal. Naloxone competes at those same receptors and therefore cuts the pathway short. Subsequent work with receptor imaging and further blockade designs has traced the same logic. Anticipated analgesia is not a free-floating story the cortex tells itself. It is a physiological cascade the nervous system runs when context predicts safety or drug effect. This is why an inert pill can quiet real pain without an external agonist molecule. The dose can be empty while the body's receptor systems still fire under the cue of care. Context is not all in the mind as metaphor. It talks to measurable receptor systems. Informing patients about possible side effects raises the rate at which those symptoms appear. Nocebo research reviewed and extended by investigators including Luana Kalloca and Fabrizio Benedetti documents that rise on both inert placebos and active drugs, in clinical trials and in experimental pain settings. Negative expectation is the mirror of placebo. A warning names headache, nausea, drowsiness, or heightened pain as likely outcomes, and the nervous system treats the naming as a forecast. Attention locks on those sensations. Anxiety and learned associations amplify ordinary bodily fluctuation into reportable symptoms. In experimental designs, verbal suggestions of worse pain or side effects, paired with inert treatments or controlled stimuli, increase symptom reports and shift autonomic and neural markers even when the physical input is unchanged. The clinical frame that can recruit endogenous opioids toward relief can also recruit descending and autonomic pathways toward harm. Framing is not neutral paperwork. It is a physiological cue. Set beside the earlier findings on expectation, ritual, and endogenous opioids, the pattern is consistent. A large share of what people experience as treatment is the nervous system answering to ritual, prediction, and clinical meaning, not only to the molecule in the pill. Genuine benefit, therefore, need not wait on an active ingredient alone, and genuine harm can arrive on words and warnings. What does the work is often the brain's forecast inside a medical context. The old assumption that only chemistry in the pill can count does not hold. The body keeps the score the clinic teaches it to expect.